All right, welcome. So before we get started, I just want to take a brief moment to thank Diagnostic Solutions for inviting me to speak on such an important topic. Today, we're going to be talking all about how do we bridge the gap between conventional medicine and functional medicine utilizing the GI map by Diagnostic Solutions. Before we jump into today's lecture, I would like to just pause for a moment and introduce myself for those that are unfamiliar with who I am. My name is Jade, and I am a board certified physician assistant. I have spent the entirety of my career specializing in gastroenterology and subspecializing in hepatology. I've worked in both acute and outpatient medicine, and so my experiences are very diverse across the GI space. We're going to talk here in just a couple of slides about my backstory, but a couple years into practicing GI medicine, I was diagnosed with ulcerative colitis and really frustrated with the one size fits all approach and lack of improvement despite conventional therapies. I set out on a quest to heal myself naturally, and through utilizing the GI map, I was able to reach remission within 2.5 years. And after I did that, I started practicing as a gut health consultant, and I had the privilege of working with women in 20 states across America and in 4 countries heal their longstanding digestive dysfunction naturally utilizing the GI map. It was after that point that I then transitioned from working as a gut health consultant to actually working as a gut health educator and educating physicians and practitioners and coaches how to interpret the GI map and how to create advanced root cause healing protocols that actually work and drive the needle towards healing and sustained healing. And I now also practice as a business mentor as well. And I am the founder of Microbiome University, which is an on-demand educational platform that helps practitioners bridge the gap between GI map interpretation and protocol development. And you can learn more about Microbiome University and this membership at theguthealthqueen.org/MU. So the purpose of today's webinar is really to help you as a practitioner bridge the gap between conventional medicine and functional medicine utilizing the GI map. So we're going to discuss what exactly is the GI map, why is it a useful tool to help bridge the gap and to provide data and answers for long-standing symptoms. We're going to discuss some common roadblocks that you might come up against as you start ordering this test. How do you establish a referral network? When would you want to consider referring out? And then we're also going to review some frequently asked questions between conventional and functional medicine testing that I seem to get quite frequently from practitioners that they are hearing from their patients and clients. Since we're going to be talking today about how do we bridge the gap between conventional and functional medicine utilizing the GI map, I thought it would be quite fitting to show a little glimpse into my personal journey in overcoming inflammatory bowel disease utilizing the GI map. So several years into practicing conventional medicine, I came down with these really ambiguous symptoms, some GI related, others not. And after having several conversations with some of my colleagues, I ended up undergoing a colonoscopy, which came back positive for moderate to severe ulcerative colitis. And I went on the conventional treatments of high-dose steroids, Lialda, Humira, and despite these biologic agents and steroids, I really was not feeling better. And I, a year later, had a subsequent colonoscopy, which again revealed really no change. That's what you're seeing here on the screen is pictures from that second colonoscopy showing pretty significant inflammation at the appendiceal orifice and in the ascending colon. So at this point, I was really feeling frustrated and down with my lack of improvement, despite following very strictly with the conventional medicine model's treatment. And so at this point in time, I discontinued all of my prescription medications, and I kind of went down the path more of root cause, functional medicine, and I ordered a GI map on myself, and I'll show you those results in just a second. But it was at this point that I ordered a GI map, analyzed my microbiome, and really shifted my focus towards, okay, how do I optimize my nutrition, my lifestyle, and how do I utilize targeted supplements based on what my unique microbiome is showing at this point in time. And within 2.5 years of ordering that GI map and shifting my focus into a more individualized approach, I'm happy to say that I reached full remission, both symptomatic and endoscopically, naturally. And I have been in remission since that time. And so this is a beautiful example, personal example, of how you can utilize a GI map to bridge the gap and to help someone actually truly heal and sustain healing long term. So here you are actually looking at my original GI map results from way back when I was first diagnosed with ulcerative colitis. Came back positive with H. pylori, low undetectable limits of Akkermansia muciniphila, very low levels of Faecalibacterium prosnitzi. Although we're not going to be diving in and I'm not going to be educating on inflammatory bowel disease, these are very common findings and patterns that are associated with a diagnosis of ulcerative colitis. And some more of my original findings showing high levels of Bacillus species, elevated levels of Streptococcus species, and then Candida, which again, not shocking because I was on really high dose prednisone at this time. And then I had, as you can see on this slide, a really low elastase level and an elevated anti-gliadin IgA. Although not flagged, it's still important to mention here that there was some occult blood that was positive in the sample. And there was also a calprotectin level of 141. We're going to talk about calprotectin during this webinar. There's a lot of discrepancies when it comes to actually reading and interpreting a calprotectin level. And I thought it would be fitting to include the repeat colonoscopy images since I showed you the original findings of inflamed mucosa in the appendiceal orifice and the ascending colon. Here you're looking at colonoscopy results post GI map adjustment about 2 years later with healthy, thriving mucosal tissue. So when I was diagnosed with ulcerative colitis and I started thinking about, what are my alternative options towards healing? When I first learned about the GI map, I remember thinking to myself, what is this? And how is this different than the stool samples that I'm ordering for patients in conventional medicine? So I think it's really important that we actually address this and we talk about this. And so this will be sprinkled in several times throughout today's webinar. But let's start with just what exactly is the GI map? Right? Maybe you are that practitioner that I was at that point in my career that's like, maybe I want to start ordering this, but I don't really know what it is. Or maybe you are a patient and you're wanting to talk to your conventional practitioner about ordering this test. Or maybe you're wanting to establish a referral network and you don't really know how to describe the test that you ordered to the conventional practitioner that you're building a referral network with. So let's talk about it. What is the GI map? The GI map is going to quantitatively assess an individual's microbiome, paying specific attention to bacteria, parasites, and viral pathogens that can cause disease, that can disrupt the normal microbial balance, and can contribute to chronic GI illnesses or symptoms. Okay, and Diagnostic Solutions utilizes quantitative PCR technology on a single sample to actually identify these targets. The test is also going to assess for intestinal health chemistries such as calprotectin, secretory IgA, occult blood, and elastase. So these are all going to help to tell us a little bit more about, is there inflammation present? What is the immune response in the gut? How's the enzyme production, and much more. Okay, so essentially what the GI map is doing is taking an individual stool, looking at that stool sample, and identifying specific bacteria, viruses, parasites in that stool sample, and not only giving us a yes, it's present, or no, it's not. It's actually giving us quantitative data, which is telling us how much of it is present, if it is present. And that is also very important when it comes to interpreting the testing and drafting protocols. Now that you have a better understanding of what the GI map actually is, let's talk about why it is a useful tool. I'm sure that there are some practitioners tuning in that can identify with this. It's not uncommon to order testing on a patient who's had long-standing GI symptoms and the testing to come back negative. And you're left scratching your head thinking, I believe you. I believe that you're experiencing these symptoms, but your testing is normal. And if your testing is normal, there's nothing that I can do to help you. I don't know how to help you if your testing is normal. And it leaves you as a practitioner, at least in my experience, feeling very frustrated. Like, how can I help you if the testing is negative? It shows normal, right? So the GI map becomes a useful tool because it's not giving us a black and white yes or no, this specific species is present. It's giving us quantitative data, and it's telling us on a spectrum how much of this specific strain do you have. That changes the conversation then, because we know that specific commensal species produce certain vitamins and produce certain neurotransmitters and a bunch of different postbiotics that influence the way that we feel and the symptoms that we experience. So the GI map provides us a roadmap forward of how to help an individual, because the conversation now starts to shift from saying your results are normal, there's nothing I can do to help you, to this species is not at an optimal level. Let's try to increase your consumption of this food, which we know feeds this specific bacterial strain. Or let's make a modification to this specific lifestyle aspect, because we know that this lifestyle or this specific thing can impact the level of this bacteria. I would also say that this test is a useful tool because it assists us as practitioners in discerning an individual's digestive capacity and the response of the immune system to the gut, or what is actually happening in the gut. Because I work as a gut health educator and I'm working very closely with practitioners who are in those first 1 to 3 years of transitioning out of conventional medicine into this more functional root cause healing space, one of the first questions and the most common question that I receive from practitioners is, when should I consider ordering a GI map? Well, given that the digestive tract really serves as the gateway between the internal and external environment, and considering all disease originates here, there is never a time when we shouldn't be utilizing this test, in my opinion. It proves particularly beneficial for individuals that are struggling with like chronic elusive symptoms, whether that's confined to the digestive tract or it's manifesting systemically. So on this slide, you're going to see a list of GI symptoms, autoimmune conditions, and allergic diseases that would warrant a microbial analysis, such as abdominal pain, bloating, constipation, diarrhea, IBD, certain cancers, diagnosis of IBS, diagnosis of SIBO, rheumatoid arthritis, asthma, eczema. The list goes on and on. So in my opinion, my response is always. We should always be ordering a GI map. Despite the GI map being an exceptional test, many conventional practitioners express reservation, and I want to discuss those common roadblocks or apprehensions and why is this the case. In my opinion, the primary obstacle faced by practitioners is just that they're unfamiliar with the test. Both patients requesting the test and practitioners unfamiliar with it often pose questions such as, like, what is it specifically searching for? How is it conducted? Is there scientific research to support its validity? Can it actually be deemed accurate? Do the test findings genuinely contribute to helping patients? How can protocols be developed based on these findings? Is insurance coverage available for the test? And does it serve as a replacement for traditional medical testing? So to alleviate some of the confusion, and also because I just want to bolster and increase your confidence in ordering and discussing this test with colleagues, I'm going to give some just kind of concise, to the point answers for each of these questions. So number one, what is the test looking for? The test is looking for pathogenic bacteria that are capable of producing acute illnesses, looking at commensal species responsible for postbiotic production, like short-chain fatty acids, vitamins, neurotransmitters. It's also assessing for opportunistic species, which can lead to inflammation, autoimmunity, in addition to looking at viruses, parasites, fungal overgrowth, and the digestive capacity of an individual. Okay, question number 2 is, how is the test completed? It's completed by collecting a stool sample in the privacy of your own home and submitting it to a lab via mail. Okay. Question number 3, is there science to support this type of testing? Yes, absolutely. I would encourage you to review Diagnostic Solutions white pages. You can find that on the website. They also have an interpretive guide and a methodology guide. And you should, feel free to review that, share that with your conventional colleagues, and also share it with the patients or clients that you're considering ordering a GI map on. Number 4, is it accurate? Yes. The GI map has less than a 10% coefficient of variation when the set standard is usually 15%. So this means that 2 identical samples that are tested would have less than 10% variation between the readings, which is phenomenal. Okay, number 5, how do I create protocols around the findings? Well, I am a huge proponent of targeted protocols based on research, and that is what I review inside my membership, Microbiome University, as opposed to broad spectrum supplements. So if you're looking to order and create protocols, I would encourage you to either look at Diagnostic Solutions Interpretive Guide or find a mentor that can help you in this space. Is it covered by insurance? So insurance payment will depend on the insurance provider, although the test is approved by Medicare. Number 7, does this test replace conventional medicine tests and procedures? I don't think that there is one test that should replace another. So all test and procedure results should be used in combination and compared against the person, their history, their symptoms, etc. And it's almost like we utilize all of the objective data to make informed decisions about how do we move forward to help an individual. So let's say you're practicing as a consultant or a health coach, a dietitian, and you order testing, you order the GI map on a client, and it comes back with concerning findings that require additional testing that's just beyond your scope of practice. What do? I suggest having a referral network in place. So, maybe a handful or more of practitioners that understand what you do, how you help individuals, what you're ordering, so that when these situations arise, you have colleagues in your back pocket that you can refer your patient or client out to. So my suggestion is that you create a referral kit. Okay, a referral kit is going to be a branded PDF that has an introduction of who you are, your practice, or how you help individuals. It would have maybe a picture of yourself, your credentials, any publications that you've been featured in. You would clearly list out your area of expertise and focus, how you help clients. You would outline the testing that you order. So in this case, you would include the GI map, what it is. So you can go back in this webinar, in the recording when it's posted, you can go back and you can pull out from that slide where I described what the GI map is, what it assesses, why it's beneficial. I would also include in that referral kit maybe one case study with before and after results and testimonial from that individual, and then how you can be reached. So once you get that referral kit put together, then you want to actually use it to build your referral network. And there's different ways that you can do this. You could email some local practices your referral kit, this PDF that you put together. Or what you could do is you could do like a local drop-off. So you could print out that PDF and go to a couple GI practices nearby and drop that kit off. You could go to some local networking events or maybe host a lunch and learn at a GI practice. take in some lunch and talk to the physicians about who you are and how you help individuals, and that you would like to build a referral network so that they can refer out their IBS patients who've exhausted all medications and are still not getting better. They can refer them to you, and vice versa. If you have a client that you need additional testing outside of your scope of practice, you can refer them to that GI practice. So kind of just mutually beneficial in helping and serving patients and clients. So it's not uncommon for me to hear probably about once a week from a practitioner, Jade, I got testing back on a patient or a client. It's got some concerning findings. I'd like to refer them out for a second opinion or to have a colonoscopy done. What do I say? Or what do I do? How do I refer them out? So to alleviate some of that stress, I thought, why don't I include a slide here that we talk about, what do I say to the physician, and maybe an example of how to do this. So I always recommend to practitioners either have a phone call, so call the physician that your patient is wanting to go see, or you could, if you don't want to do a phone call, you could write a letter that patient of yours could take and present to the physician or practitioner that they're going to see in the conventional space. And I recommend introducing yourself, presenting the symptoms of your patient, clearly listing out what is the testing that you ordered and a description of the testing. Present your concerns, right? So what were the findings that made you concerned in the first place, and maybe any next step suggestions that you have. And then how can you be contacted if that physician or practitioner needs to get a hold of you. And make sure that you attach the testing results to the written statement that you're giving if you're going to write a letter. And I would also suggest that patient or client, when they go to see that conventional practitioner, that they take a copy of their results. Okay, so here's an example. This is what this would look like if I was doing this for one of my patients or clients. I would say, hi, Dr. Smith, my name is Jade. I'm a board certified physician assistant specializing in functional medicine. I have a client I'm referring to you for further evaluation. She's a 32-year-old female presenting with bloating, diarrhea 3 times a day, urgency and floating stools. I ordered a quantitative PCR stool test on her to analyze her gut microbiome and rule out parasites and yeast. Her findings are positive for calprotectin of 305, occult blood of 20, low Faecalibacterium prosnitzi, high Enterococcus species, and high Prevotella species. Her symptoms, individual findings, and patterns raise concern for an underlying diagnosis of inflammatory bowel disease. She is colonoscopy naive. I appreciate your participation in this case in a second opinion. Please feel free to contact me with any concerns at jade@theguthealthqueen.org. Or I would give my phone number, right? So I'm clearly saying, this is who I am. This is the backstory of this person. This is the testing that I ordered. These are the test findings. I'm really concerned because these test findings could indicate underlying inflammatory bowel disease. She's never had a colonoscopy before. I think it would probably be a good idea to have a colonoscopy, but I'm going to leave that up to you. And I'd like a second opinion from you about whether or not you think that's appropriate. If you want to talk to me about anything, please reach out to me, and giving your contact information. So this is how you would actually present a case to somebody working in the conventional space that you'd want to get a second opinion from, or somebody within your referral network. All right, now to the fun part that everyone has been waiting for. Now that we've gone through what is the GI map, why is it a useful tool, and how do we build a referral network, and how do we communicate concerning findings, let's talk about when should we consider referring out or seeking additional testing on our patients and clients. As we start diving into some specific scenarios where we would maybe want to consider referring out, I also want to say there's a lot of other scenarios. This webinar would be way too long if we went into the intricacies of every single finding. So I'm going to keep it pretty minimal. We're going to just talk about 4 here, with the first one being elevated calprotectin. So calprotectin is a zinc and calcium binding protein that is released by neutrophils, which are the white blood cells. So the presence of calprotectin in the stool is a direct reflection of neutrophil migration into the GI tract, usually from either infection or from inflammation. Okay, so I wanted to talk about what are some potential root causes that would require further evaluation. And maybe that's outside of your scope of practice when you would need to consider referring out. The first thing that when I see an elevated calprotectin that starts to kind of flag in my mind is inflammatory bowel disease. Could there be underlying inflammatory bowel disease? There's a lot of discrepancies in interpreting calprotectin. For me, I personally start having heightened concern for IBD when I see a level over 120, and we'll talk about this a little bit later. Another root cause that we would want to rule out would be celiac disease, in addition to ischemia, so lack of blood flow coming into a specific part of the GI tract. This is most commonly going to be in the watershed areas, which is going to be in the descending colon on the left side, and then cancer. Having an underlying colorectal cancer that has not been diagnosed could also be a reason for an elevated calprotectin level. So some patterns of concern is when you're seeing a heightened or an elevated level of calprotectin with also an occult blood, like a positive blood in the stool, and also seeing anti-gliadin IgA being elevated. So if you're seeing these patterns, that would start raising some concern, and I would start asking some questions to this patient of, have you ever had testing for celiac disease before? Have you ever had a colonoscopy? Is there somebody in your family that has a history of colon polyps, colon cancer, inflammatory bowel disease? If any of these answers are yes, I would start thinking about, okay, maybe this person needs to have a colonoscopy done or some sort of imaging. And if that is outside of your scope of practice, then this is when you would want to consider referring. So scenario number 2, when we might want to consider referring out, is going to be an elevated occult blood. This test measures hemoglobin, which is the protein of red blood cells. The stool sample is combined with a test tube liquid and placed into a machine with antibodies that will actually bind to the hemoglobin. So if the antibodies bind in the test tube, then it indicates that hemoglobin, red blood cells, are present, right? And that's how it's identifying, yes, there is blood present. It is important to note that this test is only going to detect intact hemoglobin, which is actually going to come from the lower GI tract, from the colon. It will not identify partially degraded hemoglobin, which will come from the upper GI tract. So globin of human hemoglobin is actually degraded by proteases, which are present in the upper GI tract. So if an individual is bleeding internally and it's coming from the small intestine, that blood is going to be partially degraded and not picked up on this testing. So please keep that in mind when you're seeing this level elevated. It's an indication of lower GI tract bleeding. So some potential root causes requiring further evaluation is going to be, again, inflammatory bowel disease, but more specifically ulcerative colitis coming from the lower GI tract, adenomatous colon polyps because they can bleed, and colon cancer. Again, there is a lot of vascularity coming into colon polyps and colon cancers, and we can see small bleeds occurring. So these would need to be ruled out when we're seeing a high level of occult blood. Now, there are some reasons for why someone would have a low level of blood in the stool that doesn't require further evaluation. That's going to be diverticulosis, hemorrhoids, fissures, a woman collecting a sample on her menstrual cycle and there being cross-contamination. Those would not warrant a referral, though. So the ones that are going to require a referral are going to be inflammatory bowel disease, colon polyps, and colon cancer. Some patterns or findings that would raise concern for that on testing of those more serious underlying root causes is going to be a really high occult blood, but also seeing calprotectin, marker of inflammation, and then also an elevated Fusobacterium species. There is studies coming out that elevated Fusobacterium species correlates with colon cancer and is actually a bacteria that's found within dissection of these cancers. So just keep that in mind if you're seeing those patterns. If there's a family history of adenomatous colon polyps or colon cancer, or a family history of inflammatory bowel disease, or this individual is past due on a colonoscopy, all reasons to consider referral out for further investigation. Scenario number 3, when we might consider referring out, is going to be a suspected Clostridium difficile infection with positive toxins. So Clostridium difficile is an opportunistic, spore-forming, toxin-producing bacteria that can lead to profuse watery diarrhea and fulminant colitis. There is really no mistaking a C. diff infection. If you know that you have C. diff, it has a specific smell, a specific texture, and there's usually very profuse watery diarrhea where individuals cannot leave their house when they have this specific infection. One of the things that I want to make sure that we cover is that the GI map assesses for the presence of toxin genes, not active toxins. So this means an individual can be an asymptomatic carrier of this bacteria, but not have an active infection. So the only way that we can diagnose C. diff is to actually have the toxins present, which the GI map is not assessing for. Okay, so when would we want to consider why would we consider referring out in this scenario? Because there's a high mortality rate with fulminant colitis, which can occur in the setting of C. diff. We also see significant dehydration occurring, and so if you're not in a position to be able to manage that, you might want to refer out. There's also a high level of relapse and recurrence. So if you don't feel comfortable and confident in managing this, it might be a scenario where you would consider referring out. Some patterns of concern on testing are going to be seeing the C. diff toxin genes present and an individual having symptoms that correlate with having a C. diff infection. They were just on antibiotics, now they have acute watery diarrhea, passing a lot of mucus in the stool, foul-smelling stools. All of those would be that would raise concern, in addition to having elevated levels of calprotectin. Calprotectin in the setting of C. diff would make you start thinking, is this person pushing towards a fulminant colitis picture? As well as seeing secretory IgA being elevated, so the immune response is going up. And then if you're seeing occult blood on stool, occult blood in the stool, all of these raise concern that maybe this is active C. diff that could result in a fulminant colitis. And if it's outside of your scope of practice, you might want to consider referring here. And finally, we would consider referral out for elevated anti-gliadin IgA. So this is actually, these are antibodies that are targeted at gliadin-derived peptides. I'm not going to go into too much detail here about what exactly is anti-gliadin IgA. Inside DSL Academy, Kat Simmons does a phenomenal job actually going into more detail about what exactly is anti-gliadin IgA, and I really encourage you to spend some time going into DSL Academy and looking through and listening to some of those lectures inside. But some of the potential root causes requiring further evaluation are going to be celiac disease, right? Because anti-gliadin IgA are antibodies being produced against gliadin, which is coming from gluten-containing products. So I want to talk about, there's two patterns for me that raise concern that celiac disease could be at the root of an elevated anti-gliadin level, and that's going to be if you see a really low secretory IgA with a moderate to high anti-gliadin, that should immediately start triggering for you that celiac disease could be present, because even with reduced immune capacity, we're still mounting a significant response. The second is going to be if you see an anti-gliadin IgA being elevated and a secretory IgA being over 5,000, that's also going to trigger, at least in my mind, that yes, absolutely, we could have underlying celiac disease here. So keep those in mind when you're analyzing testing, that those two scenarios should definitely, you should be asking the individual, like, have you had testing for celiac disease before? Is there anybody in your family that has celiac disease? How do you feel when you consume wheat? Why do we care about celiac disease or knowing if somebody has celiac disease? Because long-term inflammation when somebody has celiac disease, anytime they consume gluten, it's going to break down the villi in the small intestine, which is going to reduce absorption, and it's going to lead to inflammation. And long-standing inflammation can lead to tumorigenesis, so creating like a lymphoma or some sort of cancer in the small intestine. Also, the breakdown of the villi means that we have reduced vitamin and mineral. We have reduced absorption of vitamins and minerals, so that can lead to deficiencies. We can see low bone mineral density, autoimmunity, anemia. So there's a lot of underlying conditions that can result from continued consumption of gluten. So if somebody has celiac disease, we need to know it so that they can be forever and ever gluten-free, which is a different conversation than non-celiac gluten sensitivity, which Kat does a great job discussing in that lecture inside of DSL Academy. Now that we have covered 4 scenarios where you maybe want to consider referring out for a second opinion or further diagnostics, let's dive into some frequently asked questions. I'm going to cover only 4 here, and then we'll open it up for an open Q&A if anyone has any questions for me. But these are some of the most common questions that I get from practitioners when they start ordering a GI map. And they start seeing or hearing discrepancies from patients between conventional tests and the results that they're getting on the GI map. One of the most common questions that I get from practitioners is, my patient had an endoscopy done and H. pylori biopsies were negative, but I'm doing a stool sample via the GI map and the test is positive. Why is that? And there's a lot of reasons for why there could be discrepancies in testing. And I will say that my favorite is to do quantitative PCR stool testing, which the GI map utilizes. The reason why the biopsy results can be flawed is because there can be a lot of human error associated with it. So it's the site that the sample was taken. Was there enough tissue taken when the sample was collected? How many biopsies were collected to be analyzed? What was the staining method that was ordered? Was the individual on acid suppression at the time that the biopsies were taken? And what is the experience of the pathologist that's actually reviewing the biopsies? So I can, what I can say is that when I was practicing conventionally in GI, we would order urease testing on the biopsies, and H. pylori has evolved with time to be able to move back and forth it can shapeshift and move into a coxoid form of H. pylori. H. pylori can move into a coxoid form, which actually does not produce urease. So there can be false negatives on testing. If the bacteria has shifted into a coxoid form and is not producing urease, then it's going to look negative on testing when you're testing for urease, which we see quite frequently in biopsy testing and also in breath testing. So there's a lot of reasons for why, but I would say a lot of them are because of human error or staining method. And if you're unfamiliar with the shape-shifting of H. pylori, Diagnostic Solutions has a wonderful training on H. pylori, and I also have a very in-depth training on H. pylori inside of Microbiome University. So I would encourage you to do a little bit more research so that you truly understand this elusive bacterial species. Moving on, another question that I get quite frequently is, why was my breath test negative for SIBO with my GI physician, but my GI map shows opportunistic overgrowth? Okay, so I think it's important first and foremost that we establish that the GI map cannot confirm or diagnose SIBO. The only way to diagnose SIBO is to identify off-gassing of a specific gas above a specific threshold. So for example, a lactulose breath test is going to identify hydrogen and methane levels in the breath, and if it is above a specific threshold, then an individual is labeled with SIBO. The GI map is different because the GI map is not identifying gas or testing for gas, but rather what it is doing is testing for specific bacterial species and strains that are capable of producing gas. So if we're seeing overgrowth of opportunistic species, that would be labeled as dysbiosis, not SIBO. So the GI map, you can diagnose someone with dysbiosis, but you would have to send them for a breath test to confirm SIBO. Okay, so the GI map is not looking for gas, it's looking for specific species that produce gas. And I've included a table here that shows you the GI map is assessing for these specific strains and then what gas do they produce. Okay, so the primary hydrogen producers are going to be Faecalibacterium prausnitzii, Roseburia, Bacteroides phyla, and Firmicutes phyla. The primary methane producers are going to be the Methanobacteriaceae family. And then hydrogen sulfide producers are going to be Bacteroides fragilis, Escherichia, Enterobacter, Desulfovibrio, Morganella, Pseudomonas aeruginosa, Staphylococcus, Citrobacter, Klebsiella, Proteus, and Fusobacterium. So if you are seeing these species elevated, then you could consider sending somebody for a breath test to confirm the diagnosis of SIBO. But that is the discrepancy. There is a difference between looking for specific bacterial strains versus looking for the the gas that is produced by that specific bacteria. Another frequently asked question is, my GI map shows positive C. diff toxin A and B, but my testing with my GI physician is negative. Why? Well, again, we need to first identify that the GI map does not assess toxin level directly, but it's looking for toxin A and B genes using quantitative PCR testing. So C. diff can be part of a normal gut microflora, and genes can be present without active infection or toxins. So conventional diagnostic is for C. diff is toxins and culture. So finding a positive testing on a GI map does not mean that an individual has active C. diff infection. You have to get a culture and toxin levels to confirm a diagnosis. And the final frequently asked question for this lecture is going to be, does an elevated calprotectin indicate IBS or IBD? My answer is hard to say. There's a lot of discrepancies when it comes to analyzing a calprotectin level, and there's a lot of differing opinions. This has to do with antibody production, processing protocols of a lab, variations in calibration. For me, my cutoff is around 120. When I start seeing a calprotectin level above 120, my mind starts leaning more towards inflammatory bowel disease. Below that threshold, I'm thinking more along the lines of irritable bowel syndrome, underlying dysbiosis, and could this individual be taking something that could be skewing the level, right? So NSAID use can actually lead to elevation of a calprotectin level. But for me, my cutoff is around 120. And could it indicate IBS or IBD? Yes, both, or maybe neither, right? IBS is just a label that we give to an accumulation of symptoms. So I would encourage you to look at the calprotectin level and compare it to the person's history, their symptoms, their family history. For more information on calprotectin and how to interpret that level, I would encourage you to refer to DSL's white pages for more information, and you can find that on Diagnostic Solutions website. All right, that is going to conclude today's webinar. And please know that we have only just begun to scratch the surface in this webinar on how do we bridge the gap between conventional and functional medicine utilizing the GI map. If you resonated with my teaching style and you would like to learn more from me, you can visit my website at theguthealthqueen.org. As mentioned previously, I am the founder of Microbiome University, which is an on-demand educational platform helping practitioners bridge the gap between GI map interpretation and protocol development. I also host comprehensive expert level masterclasses that are centered around intricate gut health topics, and I have gut health courses, mentorship, and much more. And you can learn more about that by visiting my website or following along with me on Instagram at The Gut Health Queen. Thank you so much for being here with me today and following along. And I believe if we have time, we are going to pause and open it up for some live Q&A. But again, thank you so much.
Thank you, Jade. We do have several questions today in the chat box. First one is, why was your secretary IgA not low?
Yeah, so it's a little bit difficult to interpret what was on the screen because that test was taken several years ago and there have been some updates to how Diagnostic Solutions Lab now presents the testing. So when you order testing through DSL now, you will see a graph that will be red, yellow, and green showing where someone falls on a spectrum. That test showed just a blanket number, so it won't flag unless it's above the threshold set by the lab. If I were to go back, or if you go back and look at that slide, you will see that I fell right at the upper limit of normal. And so with that being said, usually when we see a secretory IgA, which is the first line of defense in the gut, we'll see whenever there's active infection or acute inflammation that the secretory IgA level will go high first. And if that infection becomes chronic or the inflammation becomes chronic with time, as the immune system becomes depleted, then we will see the level starting to drop and go low. And so there was a trend up at that time, and that's why it looks a little bit different on the screen.
Next one, how often did you repeat the retest during your active treatment period?
Great question. I was not an informed practitioner at that time of how to appropriately utilize the GI map. So I'll tell you what I recommend to practitioners now, which is that once you complete an eradication protocol for a patient or client, I always recommend repeating testing to make sure that you've actually eradicated the targets. Eradication protocols are usually about 4 to 8 weeks, so my recommendation is around that 4 to 8 week mark that you repeat testing. If that's not, for financial reasons, if that's not feasible, then I would recommend taking somebody through a 6-month eradication and then focusing on healing and sealing the gut lining, replacing the commensals, and then repeating testing. But yeah, I would encourage your clients to at least have testing then outside of that window once a year for prevention reasons.
All right, next one. Would you also start to treat the gut or, for instance, address HPA and HPT access or detoxification first?
I get this question so frequently, so it's funny that I'm getting asked that on this webinar too. Yeah, so here's how I practice. Is that, yeah, we definitely want to be opening up the detoxification pathways. We don't want to be putting somebody on an eradication protocol if they're constipated and they're only moving their bowels once a week, because that individual, their liver is going to get so burdened with endotoxins and they're going to feel extremely unwell. Usually, whenever I have a patient or a client submit a stool testing, it takes me about 2.5 to 3 weeks to usually get those results back on my desktop. So in that time frame, I'm focusing on nutrition and lifestyle modifications for my patient or client that's going to start getting the detoxification pathways moving. So that's usually when I focus on that, is before I get those testing results back, I try to get everything moving and get the inflammation starting to settle down.
All righty. Next one. Did strep staph contribute to your IBD, and how did you decrease strep and staph in the IG tract?
Yeah, well, I think understanding that inflammatory bowel disease is very multifactorial, and so of course it was playing a role, but I don't think it was the exact reason for the diagnosis. Staph and strep are resident microbes of the oral microbiome. And so when we're seeing overgrowth of those within the small intestine, usually it should start flagging in your mind that there is something that's allowing the translocation of those bacteria into the digestive tract. And most times that's going to be coming from reduced acidity in the stomach. Now, there's a lot of reasons for why stomach acid would be low. One of those reasons being H. pylori, which on my testing, I did have H. pylori. H. pylori produces urease, which is an enzyme that helps to break down urea. And anyways, we could do a whole training on that, but H. pylori reduces the acidity of the stomach, which allows translocation from the mouth. Also understanding that chronic stress and trauma, issues with the vagus nerve, all of that also and nutritional deficiencies will impact stomach acid. So I would say that when I see staph and strep on testing being elevated, I'm looking at the mouth. When was the last time that they had a cleaning? I try to get them plugged in with a biological dentist. We start focusing, if there's H. pylori, we're eradicating that. And then also focusing in on stress would be somewhere else that I would focus on. Targeted probiotics are great. So for Streptococcus lactobacillus rhamnosus can help to outcompete, and Bacillus subtilis can help with Staphylococcus overgrowth. Staph and strep are also biofilm producers, so don't forget utilizing something to break down the biofilms there in addition to your antimicrobials.
All righty. How do you prioritize treatment if there are many abnormal markers in many sections of the IG map?
It can be very overwhelming, especially if you're in that first 1 to 3 years of analyzing, testing, and you don't feel super confident. It can feel very overwhelming. And if you're overwhelmed, your patient or client is probably also feeling overwhelmed. So I'm sure if you asked several practitioners, each one practices differently, and that's totally okay. There's so many different ways to help people. I'll tell you what I usually do, which is I first try to assess how much inflammation is present and what is the immune capacity. If I'm seeing the immune system being really depleted and a lot of inflammation present, then I will start by focusing on 2 to 4 weeks of just trying to support the immune system and decreasing inflammation. Then I will move into an eradication protocol, which is usually about 4 to 8 weeks, and targeting the specific species that I'm seeing overgrown. So this is really going to come from H. pylori, if there's any pathogens present, any fungi or opportunistic species. Once I've targeted those specific targets, then I will move into what I like to call the heal and seal phase, which is how can I focus on rebuilding the gut lining, and then this is when I will also come back to trying to remove any inflammation that's present, supporting the immune system again, utilizing probiotics, anything that's going to help to rebuild the system.
Okay. Next one, when is a good time or time frame for a client to take the stool test post antibiotics?
Great question. The minimum recommendation is 2 weeks or 14 days, with, I would say, more optimal being 4 weeks. So between the range of 2 to 4 weeks, I tend to stick with the 14 days. So if I have a patient or client that's been on an antibiotic and I want to assess the microbiome, I'll order the testing for them and tell them 14 days out from the last dose of the antibiotic.
Do gluten-free oats contain gliadin?
That's a great question. So they shouldn't if they're gluten-free. What I will say is that oats contain, and I might say this wrong, they contain a compound called avenin, which is basically the cousin of gliadin, and it is usually not a problem for celiac disease patients or clients. So the answer should be no. Doesn't contain gluten or gliadin.
That's interesting. I know that that's a hot topic right there. Next, anti-gliadin IgA can be elevated, but secretory IgA low. Patient is potential celiac, but has been avoiding gluten for 10 years.
Yeah. Well, I would say that's definitely a pattern. So if we're seeing secretory IgA being low, which, as I said earlier, indicates that either there's been chronic infection or chronic inflammation, reducing the immune capacity, and we're still seeing a really high anti-gliadin IgA, that raises a lot of concern for celiac disease, because even when the immune system is completely compromised, there's still a significant reaction to the gluten that's coming into the system. If the only way to really be able to diagnose celiac disease is that an individual has to be consuming gluten. Because when we do biopsies, if we're not consuming gluten, then we're going to see those villi rebounding, and it's going to be a false negative test. You can check genetics. If your patient or client doesn't want to consume gluten, you can check HLA-DQ2 and HLA-DQ8. Your patient or client has to have those genetics present to even be able to go on to develop celiac disease. But again, just having the genetics is not enough, because there's plenty of individuals that have genetics and don't have celiac disease. And that becomes the conversation of epigenetics, which we're not talking about here. But I hope that I'm answering this question correctly. You can, if the question is they've been gluten-free for 10 years, why are they spiking high on an anti-gliadin? I would say you want to look for cross-contamination, and DSL just came out with a new marker checking the peptide, and maybe that's something that you want to order on this specific patient.
Okay, excellent. Thank you for that. What do you do if their elastase is less than 100?
Yeah, first I want to rule out Giardia, because
Okay.
I've seen that so many times. If there's a Giardia infection, you can start to see depletion of elastase. There are a lot of root causes for why elastase would be low. The other thing I would be thinking is this patient post-cholecystectomy? Because that could be playing a role here. We also know nervous system dysregulation. The vagus nerve innervates the pancreas, which if there is significant stress or trauma, that could be reducing elastase as well. So the way that I manage it really first is dependent on what is the root cause of it. So we want to actually get down to the root cause of why is the elastase low in the first place. Is it just because there's an abundance of overgrowth that we need to focus on? But temporarily, while we're addressing the root cause, you could consider bringing on digestive enzymes to help support breakdown. Thinking about hydrochloric acid would be an option here, like betaine HCl. Bitters are a good option in addition to utilizing food.
All right. Well, Jade, those are all of my questions for you today. I appreciate your time, and I really enjoyed the presentation. And everybody, thank you for tuning in. But all right, thank you very much and have a great day. Thank you.
Thank you.